All right, everyone. Thank you very much, and I apologize for the technical issues. My name is Matt Watson. I'm, as Cassandra said, and thank you, Dr. Kerfasi, for the invitation and for that wonderful introduction. As Dr. Kerfasi said, my main affiliation with Hopkins is within the Center for Health Security, which is in EH&E. And my job there as a senior analyst is essentially to be kind of a jack of all trades researcher, doing a number of functions relating to our work that is related to protecting people's health and safety during high consequence emergencies like the one we now face. As part of my work there and previous to working there, my clinical experience is as a paramedic. I worked for a number of years in southwestern Pennsylvania, just outside of Pittsburgh, and I trained in Pittsburgh as a paramedic. So today I hope to give you kind of a broad overview of the field of EMS, and particularly as it relates to the intersection with emerging infections. I titled the talk, "The EMS Response to Emerging Infections, Infection Control in Out of Control Environments." That was originally just a reference to the basic sort of chaos that tends to dominate in the out of hospital environment. Working in EMS, if any of you have done that or have studied it, can be quite interesting in that regard. But as we've obviously seen over the past number of weeks, this out of control environment took on a much different meaning as we're facing probably what is a generational infectious disease emergency that many of us have been thinking about and trying to urge preparedness for in and out of government for many years. I should say our center has been in existence for about 25 years or so. We were founded here at Hopkins by a group of physicians that included Dr. D.A. Henderson. I'm sure that name is well known to many of you, but the association with global pandemic disease was really at the heart of the center's founding and continues with us to the work we do today. So today I'm going to broadly review EMS as a field of practice and study. Again, going over the nexus with emerging infections, which to this point has not really had significant systemic impact, but would argue that the one we now face is and will continue to have that sort of impact on a provider population that is, for a number of reasons that I'll go into, a bit uniquely vulnerable. I should say that while I do study preparedness and response in my professional role at the center and within the school, these remarks are really more based in my practical experience as a medic. So this will be very much a view from the field. And I'm really interested to hear from those of you that especially have an occupational health background and potentially have some good discussion at the end here about what I present means for occupational health research and practice. So it will be no surprise that EMS or emergency medical services as practiced in the United States is really at the forefront of every emergency response, both large and small, up to and including pandemics. Unfortunately, you can't see my slides, but what I'm looking at now is kind of a good depiction of three main aspects of EMS. EMS is really a very interdisciplinary in many ways profession and field. There's three broad domains that all sort of have a stake in EMS. The first being healthcare. Clearly, when you have a health emergency and you dial 911, you hope that people turn up that know something about the basic provision of care. and who are also able to help be that bridge into and provide access into the larger healthcare system. So EMS fills that very important role. It is also a public safety agency. What that means is, along with its more, I would argue, more well-established public health agent or public safety agencies, police departments and fire departments, really they're embedded within community to protect not only health but safety as well, and works hand in glove with those other agencies as well as with emergency management. And then there is a public health component to EMS that I would argue is probably under-recognized, but quite important. One quite concrete example of that is the use of EMS data to feed syndromic surveillance systems to try to identify off-normal events much quicker than by going through traditional surveillance systems of active reporting. So those three aspects play into how EMS and inform EMS practice in both routine and emergency operations. So just in terms, to give you in broad strokes, part of what makes EMS a bit of a challenging policy arena and research arena is that it's quite fragmented. There are multiple different models across states and even within states about the practice of EMS in general. So you have EMS that is very well embedded in the fire service, and then versus what we call a third service model. You've got emergency agencies that solely respond to 911 calls, and then you've got more integrated services that include things like interfacility transports, and those actually have quite an important role, if an under-recognized one, in emergency preparedness, particularly when it comes to decanting facilities that have been impacted by a local disaster. Obviously, in the context of a pandemic, that's quite a bit harder to do. And then there is a significant bifurcation between the volunteer and professional practice of EMS as well. Volunteer and professional. And then within provider types, people like to, if people are not well acquainted with EMS practice, they tend to caricaturize EMS providers as quote unquote ambulance drivers. And there's actually quite a lot more to it. Predominantly, there are two types of certifications. The more basic is called the EMT, or Emergency Medical Technician basic level. And then after more schooling, you go on, you can get a paramedic certification. The main difference in scope of practice is really that paramedics have the ability to administer medications. They're licensed under physicians, but they can give medications, and they can also do more aggressive airway management, such as endotracheal intubation, which I'll talk about in a moment. In terms of governance issues, EMS is licensed and it mostly governed at the state level. As I said, most EMS services operate under a physician's license. That practice is known as medical control and is also licensed at the state level. At the federal level, there is a national EMS office. It is within the National Highway Traffic and Safety Administration, or NHTSA, which itself is part of the Department of Transportation. This is a historical artifact from the founding of EMS, which was really in the 1970s quite focused on trauma care due to a large number of highway traffic accidents that were rising at that time. And that really drove the professionalization of EMS, but also I would argue now maybe a little bit of a hindrance, and I'll talk about why that is at the end of the talk. In terms of the provider population at a high level, The latest good national information we have, I believe, was last surveyed in 2011. At that time, there were reported over 900,000 EMS providers writ large in the United States. Roughly half of those are at the EMTB level or basic level, and roughly 200,000 paramedics at that time. From an occupational health perspective, these providers are often challenged. It's a very physically demanding job at the best of times. So things like lifting heavy, whether it's, patients or pieces of equipment, can really do a number on the providers. And in fact, I do believe back injuries are the number one large reason why people leave the profession. There's also treating people with infectious disease, which we'll talk about much more in a moment. EMS providers are disproportionately exposed to hazardous and bodily substances that can cause issues, and then the basic dangers and risks of transporting people in ground or air transport modalities. There is quite a significant accident rate associated with EMS, unfortunately. And just in terms of overall injury and illness statistics, in 2017, it was reported that 21,000 EMS providers report either an injury or an illness secondary to their professional duties. The CDC, in one of their more recent guidance documents, had a really nice hierarchy of controls, and this was in the context of trying to really lay out what the landscape of infection control looks like in the healthcare settings. And at the very tip of the pyramid, marked least effective, is PPE. Above it, and again, this is for healthcare facilities writ large, you've got elimination, so physically remove the hazard. In this case, this would be the patient. Replace the hazard, isolate people from the hazard, and change the way people work. So implementing administrative and engineering controls in the context of infection control is quite important in the in-hospital environment. Unfortunately, most of those modalities are not available for EMS, which leaves EMS providers uniquely reliant on PPE to keep them safe in the context of infectious disease outbreaks. Of course, the most difficult infectious disease outbreak that practitioners will encounter is the respiratory disease, which is quite a lot harder to protect against, as we're now seeing, but also see during normal flu seasons as well. So just in terms of baseline PPE, EMS practitioners in general are taught and trained to follow basic universal precautions, which is essentially boils down to wearing gloves during any patient encounter and practicing good hand hygiene post-encounter. This really comes from a focus on bloodborne pathogens, including HIV, hepatitis C, and hepatitis B virus. And while still the bedrock of good, sort of the mental habits of good PPE and keeping yourself as a provider safe, they are just that, just a foundation point in the current COVID-19 context. And then I also have to say that while those practices are well taught and well trained in the course of an EMT's education, compliance is really quite variable. And this will be a reoccurring theme, that trying to push practice through the entire EMS system is a really tall order. So just to quickly review a few of the high consequence pathogen events that EMS has played a supporting role in supporting the response to. Very quickly, 2001 anthrax, 2003 SARS, 2009 H1N1 influenza. And then there were a couple of patients who were repatriated to the United States who had an EMS encounter during the 2014, the West African Ebola epidemic. And then I believe a couple of cases in healthcare workers. I would argue, though, that by and large, the systemic impact on EMS systems and providers during those events was quite limited. It did not meaningfully reduce the ability of, at a systems level, EMS to provide emergency medical care. COVID-19 is quite a bit different. A statistic cited, I believe, last week or late the week before from the FDNY EMS branch is that 400 providers, or about 10% of their workforce, have tested positive already for COVID-19. And I saw a statistic today which indicated that 25% of the workforce has called out sick. So COVID-19, from an EMS perspective, I would argue, definitely has the potential to degrade the provision of care meaningfully across the country, not just in New York. I think this is something we're going to be seeing play out in communities with far fewer resources than FDNY and New York City writ large, which is unique for the impact of the disease thus far, but also is quite well resourced in terms of healthcare resources writ large. And of course, I have to say that there are routine infectious diseases that EMS providers are uniquely exposed to, including seasonal influenza, TB, measles, and others. So calling in just as a reminder of the importance of practicing good personal protection. There's just a few figures here, which you'll see in the slides when you review them, of an ambulance which has been draped with plastic sheeting on the inside of the patient care, the back of the ambulance, to try to limit the amount of contamination, again, in the context of Ebola. This was, that I remember being a very well covered, from media perspective, transport, where I think a helicopter actually followed an ambulance from the pickup point at the airport to Emory Hospital, where the patients received care. But again, the COVID situation we now face has far more dire systemic potential. I know everybody here has been following the COVID outbreak intimately and closely. So I'll just say a few words about the virus itself, and just a little bit about what we think we know about it, and especially how patients present and what that means for their emergency medical care. So SARS-CoV-2, which is the name that has been given to the virus, emerged in Wuhan, China, in sometime in November or December of last year. The signal that something was going on that was somewhat out of the ordinary was some essentially social media chatter by physicians and clinicians in China who had noticed a cluster of respiratory patients that they had a tough time understanding the source of. Eventually, this source was run down to an animal market in the city of Wuhan, and this cluster spread nationally in China and then internationally. What we know about SARS-CoV-2, its route of transmission, it's respiratory droplets, which means if you're within 6 feet of an infected individual who's actively shedding virus, the possibility exists that you might be exposed. and become infected yourself. There has also been a proposed role for fomite transmission. We see that with other coronaviruses as well. The mean incubation period seems to be about 5 days, although we've seen it out, I believe, as far as 14, although that's a bit of an outlier, I'm sure. The R naught is estimated to be between 2 and 4, but is also highly and exquisitely context dependent. Multiple super spreading events have occurred and been noted. But again, in terms of the transmissibility, I think it depends heavily on the environmental context in which transmission occurs.
Matt, can I ask
a number of events take place in things like churches or other mass gatherings that have gone on to spread much more widely.
Can you explain really quick what R naught is for folks?
Sure. So R naught is essentially a modeling input. It is the number of secondary cases that a primary case will seed on average. So for every one person that has it, we believe between 2 and 4 people will become infected. The mathematical models that have been built to explain, to demonstrate and to some degree predict the ongoing transmission of COVID, both in more local contexts and also globally, rely very, very heavily on the R naught value. So that's something that a lot of epidemiologists and modelers have spent a lot of time trying to pin down. So I think our best estimate at this point is between 2 and 4 people, which is not unheard of for a respiratory virus. Measles famously has an R naught that is quite a bit higher. In terms of the breakdown of illness, we think roughly about 80% of people who become infected with COVID develop essentially mild illness, and by and large don't have an encounter with the healthcare system. Roughly 20% or so need to be hospitalized, and roughly 5% need to be admitted into an intensive care unit. Those patients are quite a bit sicker and particularly are in need of respiratory support, which is where all of the focus lately has been on the number of mechanical ventilators that are available both in the federal system, but also, and more importantly, at the point of care in hospitals across the country. I think it's fair to say we have far fewer ventilators than will be needed. So hence a significant push on the manufacturing side to try to purchase, allocate, and build as many mechanical ventilators as we can. In terms of what we think, this is another one of those statistics, case fatality rate, that is deeply consequential to try to understand what the ultimate impact of this event is going to be. Most people see a CFR around 1% at this point, although that could be off by as we start to see more mild cases, and this is where the issue with testing comes in. And then finally, because EMS does concern itself with patient care, the clinical presentation is fairly straightforward. Patients who who are in true extremis tend to have shortness of breath. They tend to be febrile and have a dry cough. Once they become hospitalized and are able to get images of their chest, viral pneumonia is the primary underlying mechanism, and that's what's seen on chest X-ray and CT. For the very sickest people, they will go on to develop acute respiratory distress syndrome, or ARDS, and that requires mechanical ventilation as well as other rescue therapies. In the pre-hospital arena, the name of the game is really going to be supportive care. EMS in general has a really good track record of providing supplemental oxygen, as well as when paramedics become involved, administering fluids if the patient is dehydrated. Provision of oxygen becomes a little bit tricky in the context of COVID. There are two main ways we give oxygen in the field. One is via a nasal cannula, so that's the prong tube that goes up your nose. That delivers a fairly low amount of oxygen, 4 liters per minute. And then the other is via a non-rebreather mask. So that's the mask that you see with the inflatable bag at the end of it. So those are the two primary ways we deliver oxygen. The one thing that's changed, though, via CDC guidance is even in that sort of situation, to try and prevent aerosolization of virus in the course of providing patient care. Once you apply the nasal cannula, you're supposed to put an oxygen mask over that, which is atypical. But again, trying to be done to put in place a few more engineering controls over top of the patient to try to protect the provider. The other thing that EMS is quite well known for and practiced at is airway management, especially when you've got patients who have shortness of breath, difficulty breathing. If they are truly sick, they may need to be intubated. That can be done in the field. However, it is also the mother of all aerosol generating procedures. So I can't imagine there are going to be too many paramedics who are going to be intubating patients in the field. Much more likely is that these patients will be put on oxygen to help their breathing and get their blood oxygenation back up, and then transported to their local hospital, to the most appropriate hospital. That's actually an important point. People, they conceptualize of EMS almost as more of a logistical service than a healthcare providing service, but the decision-making around where the patient is being taken to is highly consequential and will have significant impacts on that patient's course of care and ultimately how they recover from their illness. So the difference between going to a smaller critical access hospital versus a large tertiary medical center like Hopkins, it can be significant. And then obviously I alluded to interfacility transport as well. That's another major role for EMS practice. So that's all building up to a bit of a review of the PPE ensemble that CDC is recommending for EMS providers. First and probably most importantly is the recommendation of an N95 respirator. In the situation of shortage of those respirators, however, a basic surgical mask is appropriate and is also appropriate to be applied to the patient for source control. But the gold standard guidance is for an N95 respirator. I also have seen FDA issue a couple of what they call EUAs, or emergency use authorizations. These are regulatory mechanisms that can be invoked during emergencies in order to enable the use of either medical products or medications in the context of an emergency that are available for other purposes. So I've seen EUAs for different types of N95 respirators, both those used for industrial purposes as well as a filtering type that has been done in the past month or so to try to increase the available supply of N95s and really keep those for healthcare providers. However, like all of the other PPE I'm going to discuss today, there are significant supply concerns about having enough respirators and other pieces of PPE to keep people safe. CDC also recommends one pair of nitrile or latex exam gloves to be used during patient encounters, as well as isolation gowns or Tyvek coveralls, and as well as eye protection, so either goggles or face shields that flip down and keep people from, again, exposure. Again, these are all in short supply, and I know OSHA, from a occupational health standpoint, has been quite good about emphasizing the role of donning and doffing. So putting on your PPE ensemble, but also being very mindful that the doffing is by and large where healthcare providers, EMS providers included in that, may become exposed unintentionally if doffing is not done with care and mindfulness. So there are good guidance documents on that. And then there's an excellent photograph out of the New York Times over the weekend that shows what this all looks like when it's put together. And I have to say, from a practice standpoint, I can only imagine how difficult it is to provide care in the full ensemble. I'm sure it's incredibly hot and incredibly uncomfortable just from the practitioner perspective. So you'll see that when the slides are circulated. In terms of federal policy and guidance, I'll just wrap up here so we can have a little bit of discussion. CDC has issued interim guidance for EMS. It also, I was interested to see, as I was doing research for this talk, put up over the weekend a PPE burn rate calculator, which will be a really valuable resource, I think, as healthcare systems try to continue to make sure that they have the necessary supplies to support and protect their workforce. In addition to CDC, the Department of Health and Human Services Assistant Secretary for Preparedness and Response, or ASPR, has put out several years ago now, I believe in the aftermath of the West African Ebola outbreak, put together an EMS infectious disease playbook, which provides useful planning inputs as well for this nexus of EMS practice and high consequence pathogen transmission. And then I'd be remiss if I didn't mention all of OSHA's wonderful resources on this topic. Has really been at the forefront of making sure that healthcare providers are protected. So thank you for those of you with an OSHA affiliation for that. Finally, I'll wrap up just by touching on what I think are some of the implications for both policy and practice. The first item on anybody's list when you're talking about EMS comes back to reimbursement reform. As an HPM matter, I won't go too deeply into this, except to say that Medicare and Medicaid CMS reimburses EMS primarily for transport, so really emphasizing that logistical component of EMS practice. But I do think more could be done to reimburse for the type of care provided, whether or not it ends up in an actual patient transport. Obviously, there's a huge role for the development of training materials and educational content around keeping people optimally protected, as well as outreach. I mentioned the kind of complicated landscape of EMS practice in the US. This is one area where I think more could be done. Something I did not touch on, but from a preparedness funding standpoint, one of the things that has happened over the last 20 years and that our center has been deeply engaged in tracking and advising is the rise of a structure that we call healthcare disaster coalitions. These are entities that are funded through the ASPR, There's a program called the Hospital Preparedness Program, or it started as the Hospital Preparedness Program. I believe it's now called the Healthcare Preparedness Program, and that shift is actually quite important. Because from the get-go, what these local structures do is connect hospitals with public health agencies and with EMS providers in a given locality to provide them with a little bit of funding on an annual basis to do training and purchasing and planning. And that's really quite important. And it's very important that healthcare coalitions across the country continue to include and emphasize the role of EMS providers within those coalitions. More proximally to this outbreak, I do think that EMS providers need to be considered as healthcare providers, and first on, right there in terms of being prioritized for the provision of PPE, but also in terms of testing and eventual treatment should anybody become ill. We really need these providers to feel as protected and supported as possible so that they can continue to go out and do their jobs and keep healthcare systems functioning. That's true of healthcare providers writ large, but I would certainly say that EMS providers should be in that mix as well. And then lastly, this is a little bit more of a speculative question, but with the rise of what we call alternate care sites, or essentially the tent hospitals or other structures that are stood up to expand healthcare capacity on an inpatient basis or outpatient basis, I do wonder whether or not EMS providers could transition to, some of them potentially at the higher paramedic level, transition to providing care at those facilities rather than be in the back of an ambulance. I wonder if their years of skill in providing healthcare might be better put to use that way. So with that, I will stop and take any questions. I really appreciate, though, all of your time and interest in this subject. It's one that I feel personally very involved and care a lot about. I know there's a lot of my colleagues on the front lines who are doing just fantastic work and heroic work for the country at this difficult time, and really want to do all I can and we can to better support them and keep them safe. So with that, I'll stop, and thanks again for your time and attention.
Yeah, Matt, thank you. This was super interesting. Even without the slides, it was interesting to hear about. So looking forward to seeing those. I tried to capture questions as they came up in the chat. So I have a list here. I'm going to call on some folks to ask them to unmute and ask a question. If you have questions, you can either raise your hand in the participant panel or type it into the chat box, and then I'll call you up. So the first one I saw was from Molly. Molly, do you want to ask your questions about the workforce? No.
Thank you. Thank you so much. This was really great and very fascinating. I was wondering a little bit about the surge protection, to the extent that that's available in places like New York City as kind of part of their preparation and response, and what percentage of the workforce is kind of used at any given time during a normal time.
It's a great question. So a couple of years ago, some colleagues, and I can make this reference available to you, Cassandra, did a study which looked at, so what, in Lower Manhattan, there used to be 4 major hospitals, but one, St. Vincent's, closed back in the 2009 or 10 timeframe. And we thought that this was an interesting thing to go study, because what happened at the other hospitals that remained was an increase in their patient census as a result of the closure of St. Vincent's, which was a really good case study to see how those facilities, what strategies they could employ to increase their surge capacity, which is something we're obviously seeing a major need for now. Excuse me. So it's a tough thing to really put a number on. I think if strongly pushed, an individual facility could roughly about double the number of patients it's able to take care of at any one time. But that really takes a heroic effort on the part of the workforce to add beds in places where we're usually not taking care of people, and to have a reasonable staffing ratio. So it's a really difficult thing, and we're seeing some of that play out now.
Thank you.
Super. Next question was from Julie.
Hey, Matt, it's Julie. Can you hear me?
I can. Go ahead.
Thanks. So I'm a former ED nurse, definitely appreciate the underappreciated role of EMS. And my question was really just a brief status question. I'm wondering if you're dealing with more emergency department diversion statuses, if you're being able to find places that are accepting patients locally.
Yeah, it's a good question. Very locally. So I should say I'm not working, and it's been a while since I've touched an ambulance or a patient. But I can certainly say that in New York City, they are seeing record levels of call volumes, and I would presume diversions. This is an interesting issue, though, and I think one that could actually benefit from some thinking on the public health side. It's tough to get a sense at any one time unless you're sitting in an EOC at a local level of exactly what hospitals are taking patients at any given time. So diversion is basically a strategy for those of you who aren't healthcare providers, where if a particular hospital is seeing a large number of patients, they'll say, we're on divert, or we're essentially closed to further ambulance traffic until further notice. I know many places try not to do that, but it's something that eventually during emergencies like this, you just have to do, and just to keep hospitals functioning. So as a general matter, I'm sure many more hospitals are on divert, but I don't have good insight into the tactics of that right now.
Okay, thank you.
Yeah.
So Donna had a question. Oh, Donna doesn't have a mic. Okay. So Donna said, can EMS use PAPRs?
I have heard it suggested that they could, although I've never seen that done. I presume.
Could you tell folks what that is for folks?
Sure. So the acronym it's PAPR. The acronym is escaping me at the moment. However, it's essentially a hood which pushes air, which basically makes it so that you can work without having to wear a mask and eye protection. It's an enclosed hood. It's a bit more technologically complex. I don't know that I've ever seen them used in the pre-hospital environment. That's an interesting question, though, and I'll look into that further.
Kay Schwab, I'm sorry. Oh, go ahead.
No, positive air pressure respirators, PAPR. Thanks for the quick acronym.
So Kay Schwab, I'm not sure what, there we go, perfect. You want to ask a question?
Yeah, hi, Matt. This is Kellogg Schwab. Somehow we have cryptic things on there. Thanks for the very informative lecture. So I was a paramedic for 7 years, about 30 years ago. Mm-hmm. And when we were in rural North Carolina, it was methamphetamines were coming on board. And so as we got into situations where it was really dangerous, we developed a protocol where we as personal paramedics would wear self-contained either breathing that we borrow from our firefighter buddies or half-face respirators that were very rudimentary back then. My son is a paramedic now. So he's in Delaware. He's tip of the spear. A year ago when he started his paramedic in Delaware, and he's been a paramedic for several years, we bought him both full-face and half-face respirators because of my situation 30 years ago. He was not allowed to wear it because it was not in protocol. And they said that if he got sick, he would not be covered by insurance.
Yeah.
And I told him, you do what's right for you and your gut. My question to you is, we adapt to these situations. What do you see as the role of the frontline personnel adapting in real time to both the situations in hand where others have no clue what's going on? As a former paramedic, your description of chaos is so true. And so, you know, everything's chaos and you work in this bubble. How do we get them the ability to have flexibility to adapt to situations that they're the ones that see it weeks before everybody else, and then translate that?
Yeah, I think that's so important. And I should say the other half of that. Yes, we work in chaos, but it is our job as medics to try to bring some level of order and control to the chaos, or at least try to, right?
I call it the Chuck Yeager syndrome, where Chuck Yeager, who was flying before Mach 1, before the speed of sound, their planes would fall apart and he'd be dead calm and cool. And he's like, you know, tower, give me some help. I'm landing with one plane. So the idea is chaos with calmness. So
yeah, exactly. The Sully Sullenberger it might be another reference there. It is such a good question, and I think it emphasizes a real need to have frontline healthcare workers, whether it's physicians, nurses, or medics out in the field, well connected from both a policy perspective and a research perspective, to be able to have that sort of connection to have them report back to say, here's what I'm seeing, here are some of the fixes that I need urgently, not a year from now, not 2 years from now. Here's what I need. So the respirator thing is a perfect example, which is actually why I was really happy to see the EUAs get put in place so quickly from the FDA perspective, to try to make those more available. Those things, as we all know, take time to trickle down into the practice arena, though, and it is a hard problem. But as you said, you know, you kind of at a certain point have to do what's right for you, so you can, you know, be okay with, you know, yourself, that you've done the best job you can. And another aspect of this is actually making sure that employers across the board are putting in place protections for not only the employee, but the employee's family. What we know about from the willingness to respond literature is that providers feel much more comfortable and able and empowered to respond to an event like this pandemic if they know their families are somewhat well, you know, more well protected. So that's critical.
Thank you.
Thanks, Kellogg, for the great question. There's a question from Kritika. She's having an issue with her mic, so I'm going to ask on her behalf. She was referencing your comment about fragmented EMS research, and she was wondering if there are efforts to make it less fragmented, and sort of what some advantages of defragmentation of this research might provide.
Yes, certainly from an occupational health perspective, there probably would be a benefit if we were able to reach each and every provider. For the reasons I mentioned, though, the landscape is quite fragmented. The most effective place to start doing some of this is at the federal level. I know there are good relationships between DOT and HHS on this. I am of the opinion that the field would be better served if the federal EMS office would move over into the Department of Health and Human Services and be a little bit more well-resourced and prioritized. That may be effective from a policy perspective. But the EMS office is trying to do national data collection and try to facilitate individual researchers answering some salient questions. I just think, almost like everything in EMS, and I try very hard not to frame EMS as this sort of orphan or stepchild of the healthcare environment, but in some ways, frankly, it is. So a lot of this is just simply an awareness raising exercise and really framing EMS as part and parcel of providing healthcare in the United States.
Super, thank you. The next question is from Simon. Simon, do you want to unmute and ask your question?
Yeah, can you hear me okay?
Yeah.
I sure can.
Excellent. Perfect. So I guess my question was, when we're not in an epidemic or pandemic, is there much training or exercises for EMTs on dealing with a mass casualty epidemic scenario?
It's a really good question. It's a bit of a mixed bag. EMS, because of its public safety character, is by culture really well integrated and used to thinking about doing things like trainings and exercises. I think one thing that we should be doing once we get beyond this pandemic is thinking a little bit more about how to use the workforce in maybe some non-traditional ways, whether it's contact tracing to support public health, or to be providing direct patient care in some untraditional settings. But certainly drills and exercises are important and definitely part of EMS culture. It's just, is there the resources and time available to devote to it during peacetime so that you're not caught quite so unprepared during wartime, to use a martial analogy. Yeah.
Then we had a question from Michelle.
Yeah, you mentioned early on in your talk that there can be a lot of variation with compliance among EMS workers in terms of PPE or other best practices. So just wondering if you had any thoughts on strategies or anything you're familiar with that can help improve compliance?
Yeah, I think a lot of this comes down to basic leadership. EMS as a field is intensely protocol driven. There's essentially a protocol for everything. And from day one in education, both at the basic and more advanced levels, the importance of scene safety and PPE is drilled into you. I would also, though, point to the instrumental use of this pandemic in terms of the ability to change behavior. People will do things they wouldn't ordinarily do or aren't trained to do on a regular basis because of perceptions of risk or personal danger, frankly. So I think harnessing some of these lessons as we get them, and this is where good on-the-ground research will be needed to help identify some of these best practices. But the real answer to your question is look at the structure and leadership of some of the highest performing EMS agencies in the country. I would point to Seattle, King County as being among the very best in terms of good structure, and their outcomes show it, I think, historically, and I think they've done a great job during this outbreak as well as I can tell.
Super.
Thank you.
We've got a question from Amanda and then Kellogg.
Hello there, thanks for the talk, Matt. My question is about the EUAs. Does the FDA already have the plan in place as to what they're going to call for an EUA? Are they predetermined?
Yeah, so that's a great question. EUAs were put in place during the sort of early biosecurity and bioterrorism concerns, sort of post-anthrax, in order to make, at the time it was really to take experimental medications that weren't yet licensed and make those available to patients and providers. We've seen their use increase over the years, so certainly we've seen a number, and I expect to see them sort of as things come down the pipeline. We'll be using these, I think, on a rolling basis to make not only pharmaceuticals, but other devices and diagnostic tests, things like that, available. I'm not aware of any other PPE that will go through this process, although somebody may invent something that looks really great and changes the way we do protection of healthcare. And that would be a way to get that quickly licensed and more quickly into the hands of those who need them. So that's really the utility of that mechanism.
Yeah, thanks. I'm glad it's there.
All right, go ahead, Kellogg.
And I know we're out of time, but my one comment to this is I really appreciate what you're saying, but I also want to draw people's attention to that the opioid epidemic did not go away when we hit this crisis. And again, for my son, who I'm in there, he was doing, his team was up to two per shift of overdoses. And then the intubation and resources that are taken for these has been compounding what's going on. So they're making just really critical choices right now in real time with not the backstop of people making, allowing them to have flexibility. So I agree with your comments. Everything's protocol driven until you get into resource constraints, right, when this is incredibly complex. So I'm going to stop there and tell it's passionate to me because it's in the family, but also what I had to deal with a little bit. But we always had resources and now we don't. So that's just something to think about as we go in this, but I'll stop.
Yeah. I can certainly say that this is an unprecedented situation in terms of, particularly on the PPE front, the types of shortages and the depths of these shortages and the way people are being forced to compete really is putting people in danger. And I feel just as strongly, Dr. Schwab, that we really need to be doing everything we can on this perspective.
Gabrielle has a question. I think we have just another minute or two. Gabrielle, if you want to ask.
Awesome, thank you. This is really interesting and really informative. I do have a question regarding the shortages of PPE and the donations that are coming in from Robert Kraft, Jack Ma, all these people that are trying to donate as many masks and PPE equipment as possible. Are we sure that these donations are also going towards EMS professionals instead of just towards hospitals? Because my concern is that all of the media attention and all of the, the big, like what we're seeing in all of the media and things like that, is we're talking about the ICU physicians and the nurses and things like that. And obviously I have nothing against that, but I'm nervous that all of the donations will be going towards those individuals and nothing will be going towards the EMS, like professionals that are, at the front lines of this as well.
It's a great question. I'm not aware of any specific mechanism to make sure that donated PPE makes its way into EMS. This is another reason why the sort of fragmented nature of the field. I mean, it's really agency by agency, or almost locality by locality. So there may be some. It's just really hard to have any kind of comprehensive visibility. But I certainly hope that's the case.
Thank you.
Well, Matt, thank you so much for a super interesting talk. Again, couldn't be more timely. So thank you. I'm sure you've been slammed with all of the work at the Center for Health Security. So thank you for taking the time to come and speak with us today.
You're so welcome. Happy to do it.
Yeah, it's so great. And if anyone wants to join us again next week, again, we're going to be hearing about some occupational safety exposures and risks in the Baltimore Police Department. You can use this exact same link from today to join us next week. I don't know, Matt, if you have any final thoughts, or otherwise we can just sign off. I'm not sure if I'm getting a bad connection. It might be on my end, maybe. Got a bad connection. Anyway, thank you everyone so much. Hope you enjoy this beautiful day. Stay safe and well, and don't forget to wash your hands.
And your cell phones.
And your cell phones. And everything else that you touch. But all right, everybody, be well. Thank you so much.
Thanks again for putting it on.